Okay, everybody, I'll take my mask off and scoot up a little bit here. Okay, so I do go to nursing facilities, assisted livings, dementia facilities, so see a lot of different behaviors. You know, it's thinking has changed in all the years I've been doing this. You know, we're really trying to go to the non-pharmacological approaches, really exhaust those options before we go to medications. And then Dr. Ross will be talking a lot about, you know, which medications to start with, you know, how to titrate them, things like that. Also finding a lot of the families have so many more resources now, and they know some of the medications and they can tell you the side effects. And, you know, I don't want my husband or wife on that, or my grandmother. And, you know, I've heard this or that. So really, we're really working a lot on the non-pharmacological therapies first before you even think about medical therapies. The only other thing I'd say about the medical therapies is doing a very good medication review to make sure some of the behaviors we're seeing are not from the medications. So med review is very important. And then, you know, you can go into the trying to figure out the non-pharmacological therapies. Also important, I think, to let the families know, especially if someone is new to the facility, that the managing behavior is the greatest challenge associated with the care of people with dementia. If you ask the families, you know, I had a new admission yesterday, you know, and where's he living at home? And it was the wife, and she said, yes. And she sounded exhausted. And she just said, and they're elderly. She says, I just can't do it anymore. Even if you're not elderly, you've got someone that's up half the night wandering around, opening and closing doors. You see all the silver driving. So managing behaviors can be major, and for the caregiver also. They get exhausted, they get sick. I'm sure you've seen how many times the husband dies and the kids come in with the wife, and they did not realize that she may also have dementia or have some type of cognitive impairment, and they've just never noticed it. So anyway, so we have to look at managing behaviors, and that's one of the main reasons for admissions to facilities. So one of the things we do a lot in our office, our clinic, in the nursing homes, I'm doing a lunch and learn next week, is a lot of working with the caregivers, with the family members about the actual disease process and how it influences behavior. We talk a lot about the physiological changes occurring in the brain. I usually give a brief demonstration talking about the different types of dementia, Alzheimer's versus vascular, Lewy body, traumatic brain injury. You know, a lot of people just lump dementia into one big basket. And of course, they're all progressive, they're all terminal. We don't have medications that are going to stop the disease process, but, you know, we're trying to manage it. But a lot of people don't have a real good understanding of what's actually going on in the brain of someone with dementia. So I think that helps when we talk about the neuronal cell death, looking at the brain of someone who died of Alzheimer's compared to someone who didn't, how smaller it is, and, you know, changes in shape and everything. So that does help people. And we say, you know, blame the disease, not the person, which is hard after they've asked the same question 20,000 times. You know, I want to go home. They're banging on the doors to go out. One of my facilities, we've had to switch where you can go in the door because they're gathered there trying to get out. So we go to another door, and I think they learned the other door may open. So they're shifting too. So we're going back and forth. Also for family members that the changes are usually irreversible. Now that's not to say, like, what we first do is a good workup. You know, we check, is it anemia? Is it a thyroid disorder? What's going on? You know, have they had a stroke? Have they had a brain injury? I had one lady that the one son said, no, she's been fine. And she was acting like it was more than just a type of dementia. The other son comes in from out of state and says, well, don't you remember, she ran into a light post and the doctor said she's really going to have some problems later on, knocked her out and this, and she has had a lot of problems. Once we get all this lab work back and maybe we do imaging, we do our neuropsych testing, we can sit down with the family and actually give them a diagnosis. We try to get the neuropsych testing for a few reasons, and one of them is insurance. I'm filling out a lot of long-term insurance forms, and they're asking, what testing has been done? Where did you get this diagnosis? So that actually gives you a diagnosis. So that helps the families, if they have long-term care insurance, to fill out the forms. And also we've had family members say, or the person say, I thought I was going crazy. They're not happy with the diagnosis, but now they know there is really something wrong with them. So also telling them, we can't reverse these changes. We can't eliminate a lot of them. Of course, if they're anemic, we can get them on iron, depending on what type of anemia, if it's thyroid. There's certain things we can do. Medications that maybe they're on the wrong medications, too much medications, we can do that. But the actual dementia, we're not going to be able to fix. And y'all know all the research trials that have been going on, and I'm actually a clinical research coordinator here in the geriatric division. So I've been involved in the bapineuzumab trial, some of the MAB trials where we do the IV infusions monthly. We were a site that got Namenda approved in the United States, actually. So really talking about that, I actually do a lunch and learn on research and what's going on with dementia. So that kind of gives an overall picture, and also behavior is beyond the control of the demented person. And that's hard, why does he do this? Why does she do this constantly? We have to really get through the families. They cannot control it. And one thing we really stress is there's no sense in arguing or trying to reason with a person with dementia. You're going to lose because they just don't understand. And it's going to frustrate both of you. So we try real hard, don't argue, don't reason, change the subject, and we'll go into some of that. Excellent. Okay, so some points to remember. All behavior has a reason, although we may not immediately know. If every time Mr. Smith walks by Mr. Jones, Mr. Smith hits him with his cane, we need a different route. Somehow the one patient is triggering something in the other. So we need a different route. And again, this goes back to your CNAs being well-trained, having the same CNAs that can see if someone's actually having a bad day, they're having a bad day. I tell students, because I have med students with me, nurse practitioner students with me, if I've assigned them someone and they're having a bad day, I said, don't see them. You will catch them another day. You're just going to aggravate them more. If they say, get out of my room, don't touch me, you have to look at that. So one big thing, is it pain? We get so many people that come to our facilities that are not on any pain medication, and I'm not saying they need to be, but a lot of them have arthritis. Most of them have arthritis, maybe osteoporosis. You can look at their backs. They have a reason to have pain. So a lot of them, we just may put on time Tylenol, something low dose, but something time, because what we have to get across to the staff is they cannot always ask for it. So the staff has to be trained to look for signs of pain, grimacing, restlessness, not being able to sit still. It could be something else, but it also could be pain. So one of my first things I do is look for, why are they restless? Are they in pain? That's one of my big things I look for. If they say they're spitting out their medicines, they're keeping food in their mouth. How many times do we look at teeth? We used to have a dental fellowship here, and it was great. And, so we have to look, this generation, the older generation, did not take as good a care of their teeth. Maybe there's one impacted, maybe there's whatever. So I load them up with Ativan and check their teeth, so we need to be sure and look for, why are they having pain? Behaviors, it is a response to the environment, the caregivers, our internal stimuli. You bring a new patient on the unit, a new resident on the unit, and it upsets the apple cart. You may have someone that hollers all the time. We've got one gentleman that claps his hands continuously, kind of drives me a little crazy. The others seem okay with it. They're used to it. But really, has the environment changed? We don't put the news on. When we had 9/11, we had many residents that kept thinking more and more planes were running into the towers. It was horrible. So no news. We just don't put the news on. So it's the caregivers is a different caregiver. So many of the families are saying, well, is Betty here today? She can always bathe my father. She's the only one that can do it. So again, caregivers that know the patient or has something changed on the unit. That's what we have to look for. We try to adapt the environment and the approaches of the caregivers to the needs of the patients. I'll have family members say, my husband always took his shower at night. He doesn't understand you giving it in the daytime, in the morning. So you have to be flexible. And what I tell everybody, this is their home. What, 10,000 a month? Most of them are now, at least. This is their home. If they want to sleep in, when they wake up, you need to have breakfast available or snacks available. If they're up during the night, they need to have snacks available, something available. It's their home. So we adapt the environment to them, not them to the environment. For those that have been around a long time, you knew Monday, Wednesday, Fridays were bath nights for this group, no matter what, whether they wanted it or not. Everyone's up at 7 around the table with shiny faces ready for breakfast. It's not going to happen. It's just going to aggravate everybody. So your better facilities will adapt the environment to that patient. We get the families to give us a list of, what time do they get up? What do they like? Things like that. Do loud noises bother them? We have a VA contract with one of our facilities, and it's been a real learning experience for us because a lot of them are Vietnam vets, Korean War vets maybe, and loud noises scare them. Different things can set them off. And when one gets set off, they all get set off. So we've learned with the VA patients, with the PTSD, it's a little bit of a different approach. And again, problems may develop when the expectations of the caregivers do not match the abilities of the patient. Someone may look very functional, but maybe they're not. Maybe they've got a frozen shoulder. Maybe they've got different things. We try to do a good physical PTOTST assessments when they come in to kind of see what their limitations are. Maybe they were walking before, but they're so far progressed that they're not walking now. So we have to look at that. And, even the family members, we have another resident, and I'm sure most of you can relate to some of these I'm bringing up. The wife could not get him to bathe or change his clothes at home. Well, we can't either. And she's upset with us. And she says, you're a special unit. You're known for dementia care. Why can't you get him to take a shower? And, he won't do it. He wouldn't do it for her. He's sure not going to do it for us. So we try to catch him at his best times. And even if it's just scrubbing his back and then stopping and then the next day doing his arms, whatever we can do. But it's not going to magically change just because they're in a dementia specialty facility. It is successful when we enter their reality. And y'all probably know this, we don't try to bring them to our reality, and we'll talk a little bit about validation therapy and other things, but they're past our reality. We need to go where they're at the time, and that will calm them down, that will make them happy, that will make them more content. And this is a real problem for the family members because they really want them, because that means they're not as bad as they are. My grandmother, who lived to be 101, would tell her sister, who lived to be 101, the sister had dementia, and the sister thought she was in Arkansas on the farm on the tractor. And my grandmother would argue with her. You, Keeter, you are in Fort Worth. You're not on a tractor, and it would confuse my great aunt. And I tried to tell my grandmother, who was very well educated, traveled the world, don't argue with her. Let her be on the tractor in Arkansas. And my grandmother, for all her intelligence, would say, but she's not on a tractor. And I'm like, well, you know that, and I know that, but she doesn't know that. So make her happy. My grandmother never could do it. It drove me literally nuts. Again, you enter their reality. And again, we talked about this, rule out a physical cause, pain, infection, medicine interaction. Again, we have to look at a lot of different things. If we've ruled out everything we can rule out, we have to tell the family it's progression of the disease state to our best knowledge. We have checked lab work, we checked kidney function, we checked everything. They're on pain medication, vital signs are stable, but if there's been a big change, it's probably progression of the disease state. Okay, next. Okay, so these are some of the common behavioral disorders. And you all have seen these. I won't go through them. I'll just say, they can all make everybody else very anxious. We do have medications for most of these. And I will say most of our residents are on an SSRI, a majority of them. Do they need it? Are they depressed? I don't know. But if they will come out and eat with the group, if they will go to an activity, that makes me feel much better, and the families too. The anxiety, that's again has to do with the environment, the sleep disturbances. A lot of them get their days and nights mixed up. We try to reset them the best we can. We use melatonin. We try to do different things, but that's going to happen. And again, you all have seen the aggression, the sundowning, and the pacing. Some of my facilities are set up like in a big square so they can walk. And then we have outdoor areas enclosed so they can get outside when the weather's nice. And it's amazing the times they get outside that really calms people down. Apathy can be very, very hard for families. It's almost worse than the constant doing something. But when they don't really respond at all and they've just got this blank look, that bothers the family. And the screaming, that can be a big one. It's just trying to keep them calm because it sets everybody off. So again, you try to use the non-pharmacological approaches, but sometimes you do have to go to medications. Next. Okay, so what we do is what triggered the behavior, the triggering event. Has there been a change in the daily routine or an interpersonal conflict? We've got one patient female patient that screams at a couple of the men she's decided to pick on, and they're tired of it, but she is just going nuts with them. So, we've tried to kind of separate them, to do different things with them. And what occurred just prior to the incident? That's what I'm always asking the CNAs, so we can see what the trigger is. Was the environment noisy? Was there too much going on? Were there too many people around? So first, what triggered the event is what we're looking for. Next. And then what was the behavior in detail? How often does it occur? If it just occurs one time, we're not going to put them on a medication or something else. And some of the facilities I go to immediately, they're like, oh my goodness, he hit this person, we need to put him on something now. And I'm like, no, what happened? Give me some more details. Was it a specific issue? Every time personal care, that can be huge. They don't want personal care. You got to do pericare if they're incontinent. But to me, verbal outburst and being resistant to care is not a reason to put them on a medication. We need to try other things first. And is it an unrecognized problem? The behaviors are a form of communication. We've got to see what's going on. Could it be a urinary tract infection? What are they trying to communicate by their behavior? That's the key point. And then what's the consequences? How did the caregiver react? Did they try to calmly remove them from the situation? Did they very calmly try to intervene? Or did they reinforce it, by scolding? You never scold or shame someone, but I have seen that happen. And what happens when the activity ceases? Is the person calm now, or are they still upset? So do they maybe need a little bit of one-on-one and reassurance? Take them outside for a walk, give them a cookie. It sounds simple, but sometimes that'll work. Do something to get their mind. It's almost like a light switch. If you switch it off or on immediately, sometimes everything's okay. So again, you have to do, we call it the ABCs, what preceded it, what was the behavior, and what were the consequences. Okay. Okay, so what we're looking at, are they a danger to themselves or others? Are they at a risk because of the behavior? Is it truly a patient problem or is it a staff problem? Now, you don't kind of want to hear that, but sometimes that could be it. Your staff that's been on a unit for a long time, if I walk in there, say, well, Barb, Mrs. Smith always gets up for breakfast and she didn't this morning and she seems agitated, she seems anxious, but she's always there first one at the table. So right then and there, I know something's wrong, something has changed. and I need to try to figure out what it is. You get someone that is constantly picking up stuff and moving it around. We had one gentleman that with any paper that was laying there, he'd pick it up, he'd move it, everyone was trying to hide their papers. Well, come to find out, he was a mailman. So what we did, we got a big cardboard box and we put slots in it and we labeled the ABCs on them, and everyone brought in their junk mail. And he put it, and he was happy. So now lots of times I've heard that's demeaning. We have women that fold towels, that do flower arrangement, that clean the table. That's what they did most of their life. That gives them peace and comfort. So we try to find out what did they do, what was their previous job, and then we try to figure out what can we do to make them feel useful. Because now that so many times, and you all have probably heard this, what do I do now? What do I do now? I hear that all the time. Where am I supposed to be? What do I do now? These people have worked their whole life, and now all of a sudden they don't have something to do. And if someone never ever did flower arranging, you can't expect them to all of a sudden love doing it, So again, a lot of family input. What do they like? So if they're not hindering the safety or health of anyone, then we try to find ways to distract them to do something else. But really, is it a behavior that's going to require a medication is what we're looking at. Can we do some non-pharmacological approach and take care of this issue? Next. So some of the non-pharmacological approaches, we always try to give them a fair trial before medications are considered. And this is kind of tricky because there are some facilities that don't tolerate what we call socially unacceptable behaviors. They won't tolerate them. Thank goodness most of the ones our group goes to gives all of us time to kind of explore what's going on, to try different things, even different medications. We've got one person, and Dr. Ross knows who I'm talking about. We're on our 4th or 5th different trial of medications. We just keep changing, trying to figure out what's going to work best for this person. And we usually get it right eventually, or else they just progressed where it's taken us too long. But usually we get it, we can get it right. We just need time sometimes. I will tell you, we've had very few that the facilities have finally said they can't stay here, they're a danger. And who else is going to take them? That's the problem. Why put a family through this? It's just heartbreaking. So sometimes to buy some time, even though this is not the best option, and Dr. Ross, you can chime in, they might go to a behavioral hospital short-term, and all they usually do is just load them up on drugs and send them back. But sometimes it does reset them a little bit. But it's kind of better than having them kicked out of the facility and trying to find another one where they're probably going to go through the same thing. So it's it's just a step-by-step thing. So first we identify the behavior, what's going on. Is there a cause for it, or are they just progressing in their disease state? And even if they are, we still need to address it. And then adapting the environment to improve the situation. You may have some people where for Christmas, everything's decorated, and for others, that's too much. They're used to the same environment, so you don't want to do too much. So you kind of got to be careful. Halloween's a tricky one too. You got to be careful with Halloween. So if caregivers are aware of the triggers, they can prevent it from happening over and over again. That's our goal. So again, a lot of this is a little bit repetitious, but we try to adjust the daily routines to focus on the person, not the task. We talked about person-centered care, attempting to force a person with dementia into routines that are convenient for the staff or for the caregivers, but they're not consistent with the person's lifelong history. It can result in resistance. If someone worked night shift all their life, they're used to being up at night. You have to kind of figure out what you're going to do to keep them occupied. And it can also intensify some of the psychological symptoms. We have at one facility, we have a namaste room, and it's wonderful. I'd like to be in there. They have these wonderful recliners, and they play this soft music, and they got these sparkly things on the ceiling, and they've got these real nice scents going on. and they rub people's hands with lotion. This is for our later stage dementia. They rub their hands with lotion. And I've seen the aides in there sitting and reading a story to them. And it is so relaxing. And we have taken people in there that have been agitated and anxious, and I've seen them calm down because it's such a calm environment. And you're dealing with the senses, smell, hearing, everything is nice and calm and works well. Next. Okay, so we talked a little bit about this, your interaction and communication strategies. Get their attention, try to make eye contact, speak directly to them to see if they perceive the message. Sometimes you have to repeat it several times very slowly. I talk fast. I have to slow myself down. And nonverbal communication, don't roll your eyes, your tone of voice, everything else, they can pick up on this. So short sentences, instead of saying, what did you have for breakfast? You might say, did you enjoy your breakfast? Something where they don't have to think too much and try to come up with an answer. And then don't say, oh, so you had eggs, were they good? Lunch will be coming. Give them time. You got to give them time, one question at a time, and allow time for a response and repeat the question if necessary. Logic doesn't work, don't do it. You'll be arguing all day like my grandmother did. You're not on a tractor. I'm like, let her be on a tractor if she wants to be on a tractor, but she's not on a tractor. And I'm going, well, how do you know she's not on a tractor? In her mind, she's on a tractor. And trying to reason with them. Everyone's going to get frustrated. Okay. And I've seen families that just are going, no, your dog's name is Spot. Your dog's name is Spot. Why are you talking about Rover? I've seen family members argue and argue. And, we try to intervene and say, no, you're all getting frustrated. They can't remember that. So do a different approach, be flexible, and don't try to convince them. I mean, what does it really matter at this point? We talked about this, change reactions. If someone's doing something good, you praise them. That's great. If they're doing something bad, don't scold or shame. Just try to get them away from that situation. And if they repeatedly ask a question, try to find out what they're really trying to tell you or ask you. If they're saying water, they may mean bathroom. I mean, you have to kind of look, because they get this word salad going and they lose words. So you have to try to figure out what they're trying to tell you. Structure and a routine. We get people that come in that, I want to go home, I want to go home. What I tell the families is, for most of our patients, most of our residents, I guess I should call them, pretty soon you're not going to get them through the door. They're going to get so comfortable with the routine that they're not going to want to leave. And that happens quite often. They get quite comfortable. They know what to expect. They know the structure, and they're comfortable with it. Sometimes, like I said, clock calendar can help those to orient to time, those that are earlier stages. Family photographs, you try to trigger a memory, favorite piece of furniture or pillow. And sometimes if someone's real agitated, I'll walk in. I've got one gentleman who is a Vietnam vet, and he's kind of volatile, but I was in the service. So I walk in and I'll start talking something military, and his whole demeanor changes, and I'm able to do an exam, and I'll just keep throwing in something military, and we'll get to talking, and it gives me time to listen to his heart, to check him over, and he stays pretty calm. Got another lady that used to ride horses. I have horses, so we start talking about horses, and her whole demeanor changes. She's just smiling, and so again, find something that they like to do and start talking about it. And you'd be surprised how you can kind of hit that light switch and calm them down and get them focused. We talked about the sensory enhancement. So we have a music therapist. Oh my goodness, that is just wonderful. They play different songs, one-on-one. Sometimes they give them instruments, jingle jangle things. They give them different things, and they just really seem to like it. And the old hymns, we got people that don't talk at all, and you start doing the old rugged cross or in the garden, some of these old hymns, and they will just sing and sing. We've got one lady, that plays the piano beautifully without any sheets in front of her. She just remembers it. Can't do a lot of other things, but she remembers it. And exercise, like I said, we've got the enclosed areas. We try to get them out. We have an exercise session. We put something on and everybody tries to go, and that keeps them occupied, and it makes them feel useful. Okay, last couple of things here. Y'all have probably heard about validation therapy. A lady named Naomi File, she established this in the 70s. And what I read about her was she got tired of seeing everyone grouping people together and try to talk to them about doing bingo or something which none of them were interested in. And she was smart. She started thinking, what are they interested in? What can we talk about? So what she did, if they said something about worried about their children, my children are at home alone, instead of saying, oh, your children are grown, they're not at home, say, well, tell me about your children. What are their names? What are some things you do with them? Oh, that's a beautiful name. Just really going where they're at. I had one lady, she was worried it was her wedding day. She wasn't going to get there. And I'm like, well, tell me about your dress. Oh, I bet it's beautiful. And, they're going to be in a church. You get a step ahead of them. You find out what they like, what they're remembering. So you enter their reality. So it gives them, like I said, a sense of dignity, identity, self-worth, because you're validating their feelings and where they're at that point in time. So go to them, try to think of something. And that, again, goes back to what they like to do. Riding the horses, whatever they like to do, start talking about that. Being in the military. I mean, with these Vietnam vets now, it's helped me because I can kind of talk with them about different things and they respond to it. We don't talk about Vietnam, but we talk about military stuff. So no, we're not going to talk about that. Redirection and distraction, again, short-term memory loss, you can use it to your advantage. You can distract them. They forget what they were so upset about. Let's go for a walk. And I've seen the CNAs do this and the nurses. They can see someone's having a bad day or they're approaching someone. They're just calmly go and say, oh, let's walk outside, or let's go to your room and look at these pictures, or let's do this, or we're going to have some ice cream. Let's go sit over here. So you distract them. And again, it's that light switch. Doesn't work all the time, but you get them onto some other thought or subject. And work on calming them down. That might be it.
Yep.